Hi, welcome everybody. Good morning, and thank you so much for joining us today as we explore findings from the California Master Plan Initiative, which is a 2-year project aimed at building local age and disability-friendly action plans in 3 California regions. Before we get started, and as folks are settling in, just a few housekeeping reminders. We can go to the next slide. Thank you so much. The session is being recorded, and we'll be sharing the recording and presentation and additional resources next week. So keep an eye on your inbox for that email, or feel free to reach out to me directly at maria@ccltss.org, and I'll pop that into the chat momentarily. Closed captioning is available, and to enable captions, you can select the CC or transcript icon from your Zoom toolbar. We encourage you to engage throughout the session via chat. Feel free to share reflections or comments or questions at any time. The agenda does set aside some time for Q&A at the end. And again, you can submit your questions at any time during the session via the chat or the Q&A, and we'll do our best to get to as many as possible. In addition, you may also raise your hand to engage in the conversation during that Q&A discussion using the raise hand icon on your toolbar, and that will put you into the queue and we'll unmute you as we go. Next slide. The California Master Plan for Aging, or the MPA, serves as a blueprint for transforming the aging experience across the lifespan. It was released in 2021, and it outlines 5 bold goals, 23 initiatives, and now well over 200 strategies aimed at building a California for all ages. The ambitious goals of the MPA can't be achieved through state-level action alone, and recognizing the important role of California communities, the Master Plan for Aging included this component, a local playbook geared towards supporting the development of local age and disability-friendly action plans. In January 2022, the SCAN Foundation provided support to 3 advocacy coalitions, who you'll hear from today, to focus on developing local MPAs that really address and tackle the unique challenges of aging in rural California communities. Over a process of 2 years, these coalitions, including the Diversibility Action Network representing Shasta, Butte, Glenn counties, the Central Valley LTSS Coalition representing Kings and Tulare counties, and the Inland Empire LTSS Coalition representing San Bernardino and Riverside counties, engaged in a process to form a local advisory committee to build on existing data, gather community input, and identify potential action items to advance as part of their local plans. As the current scope of project nears an end, these 3 regions are joining us today to share selected findings from the needs assessment pertaining to housing, transportation, healthcare access, and resource awareness, regional recommendations for program and policy implementation, lessons learned, and next steps. But before we jump in and hear from our coalitions, please allow me to introduce my colleague, Callie Peterson, Program Officer at the SCAN Foundation. Callie will give us a little background on the project and share some reflections on behalf of the SCAN Foundation. Callie?
Thank you, Maria, and good morning, everybody. And if you're in a different time zone, good afternoon. Again, my name is Callie Peterson. I am a program officer with the SCAN Foundation. We're an independent public charity dedicated to transforming care for all older adults so that they can age well in home and community with purpose. We are based in Long Beach, California, but our reach is national, and we have been a long-standing champion of master or multi-sector plans for aging, MPA. We believe that bringing people together to build trust among providers, to ensure elevating the voices of older adults and people with lived experience is critical for not only achieving what has been outlined in the state master plan for aging, but to ensure that many critical programs deliver on their intended purpose. Just next year, California will be launching the California Advancing and Innovating Medi-Cal, or CalAIM program, which aims to make access to social services much more seamless And this is especially true for those that are dually eligible, individuals that are eligible for both Medicare and Medicaid, or Medi-Cal in California. And the statewide master plan for aging has been a critical activity that supports the ramp up, if you will, of organizing and delivering programs such as these. We also know that the real work happens at the local level, where people in their communities come together and decide what components of the master plan and these new programs are most important to their constituents. We also heard, as Maria indicated early on in the process, that some of our rural communities were struggling to see themselves in what the state was rolling out. And we were excited that the California Department of Aging was ready and committed to partnering with us to ensure that we could explore opportunities and processes to ensure that not just urban and suburban communities could have master plans for aging, but so could our rural communities. So what has transpired over the last 2 years is really a testing phase and exploration into how to do this work. We have learned a lot, and there is a lot to share. And today is not the end of that process. I see today as a transition where we can consider how to package what we have learned over the last 2 years and hopefully share it so that it can serve as a roadmap, not for just other rural communities in California, but every community in California and communities across the United States. The SCAN Foundation is deeply proud of this work and deeply thankful to the partners that have been critical to achieving the successes we have achieved. I would like to recognize the California Collaborative for Long-Term Services and Supports, who has been a long-standing champion in the development and the delivery of the statewide master plan for aging. I want to thank the California Department of Aging for their leadership and thought partnership in this work all along the way. I would especially like to thank the Diversity, Advocacy, and Action Network, the Inland Coalition on Aging, and the Central Valley Long-Term Services and Supports Regional Coalition, and the multitude of people that participate in those coalitions who rolled up their sleeves, took a chance, took a risk to try something new to deliver for their communities. And I'd like to end by thanking Pauline Martinez, who's been a critical partner in this work, a consultant that was identified by the California Department of Aging early on as someone who could help us think outside the box and problem solve for our rural partners. Rural communities are amazing communities. They have unique opportunities, unique challenges. They're filled with wonderful older adults and people of all ages who contribute to California's society and all societies. We've been able to help deliver 3 in general, multi-sector plans for aging, but they really reflect 7 counties. And they are a part of nearly half of the counties in California that are currently developing and implementing MPAs. With that, I thank everyone on this call today, this Zoom webinar, for their time. We know your schedules are busy, and we hope that you find value in today's discussion. We hope you're inspired. We hope you're challenged. We hope that you can take at least one thing away from this discourse and apply it to your community so that you can support all older adults to age well in a place, in a setting that they choose with dignity and purpose. And with that, I'll pass it on to Pauline.
Great, thank you so much, Maria and Callie, for starting us off. I'm Pauline Martinez, and I've had the privilege of serving as an independent consultant on this initiative since last January. So as Maria shared in her introduction, this project started in January 2022 when the SCAN Foundation provided support to the 3 advocacy coalitions to develop local master plans for aging with a focus on addressing the unique challenges of aging in rural communities. And over a process of 2 years, these coalitions worked on creating 3 local master plans for aging covering 7 counties. In Northern California, the Diversity Action Network covered Shasta, Butte, and Glenn counties, as shown in red on the map here. The Central Valley LTSS Coalition covered Kings and Tulare counties, as shown in light blue, and the Inland Coalition on Aging worked on a master plan for aging for San Bernardino and Riverside counties, which we also call the Inland Empire, and that's highlighted in green here on the map. So to begin, I'll provide a brief overview of our scope of project that was implemented in the 3 regions. We began with forming local advisory committees in each region. And up here on the slide is an example of some of the types of representatives on the advisory committees. And there was some variation across the regions, but in general, we engaged county staff, elected officials, representatives from the local commissions on aging, the area agencies on aging, independent living centers, California Caregiver Resource Centers, United Way and 211, local health plans and community health centers, transportation agencies, housing-focused representatives, including those focused on homelessness, affordable housing, and home sharing, and other community-based organizations like the California Southland chapter of the Alzheimer's Association, CSET in Tulare County, and the Peg Taylor Adult Day Healthcare Center in Butte County. And these advisory committees met monthly and in some cases twice a month over the past 2 years to really drive this process forward. And it wouldn't have been possible with this diverse expertise really driving the charge in each of the regions. Next, we reviewed existing reports and local plans in the regions. For example, we looked at the area on agency on aging area plans, community health improvement plans, county plans for housing, transportation, and we also reviewed incoming call data to United Way, 211, the area agencies on aging, and more. And this really helped to expand our understanding of unmet needs, key issues, and current initiatives in the regions. Next, we gathered our own data through community listening sessions. So our work was modeled after the California State Master Plan for Aging, as Maria was sharing, which was launched in January 2021. And the statewide MPA is organized around 5 bold goals, as listed on the slide here: housing for all ages and stages, health reimagined, inclusion and equity, not isolation, caregiving that works, and affording aging. However, we recognized that there were some objectives that were better met at a state level. And in each of our counties, we decided to narrow in on a few domains of focus, as we can see here on the right. In Shasta, Butte, and Glenn County, they focused in on housing, healthcare, transportation. Kings, Tulare focused on housing, transportation, caregiving, outreach, and education and awareness, and food security. And in the Inland Empire, they also added in behavioral health, Alzheimer's and other dementias, caregiving, and a 7th topic was outreach and education and awareness. And the reason we selected these topics was so that we could go in depth, gathering input during the listening sessions in each of these topics. And it's obviously these topics aren't mutually exclusive. And we purposely kept them really broad so that the community could drive us, drive the direction of the local plan. So for example, in Shasta, Butte, and Glenn, the topic of housing included supports to remain in one's home. So things like in-home care and other topics. So next we selected subpopulations to engage in the listening sessions. We started off with our first listening session was with advisory committee members. And then the advisory committees identified provider groups. They partner with various local stakeholders and agencies to reach family caregivers and older adults that identified as LGBTQIA, veterans, Latinx, African American, Hmong, Native American and Indigenous, low income, unhoused, formerly incarcerated, and fire impacted. And these audiences were purposefully chosen to really have their voices elevated in the region, because we felt that historically they may not have had a great voice at the table. And in the bottom box of the slide here, I highlighted 2 links to our webinar that we presented last year in partnership with the California Collaborative for Long-Term Services and Supports. And we really went into a lot more detail during that webinar about our process for the listening sessions. So I did see in the registration today that some of you are embarking on a needs assessment in your community, and you're interested in some more information about our interview guides and our recruitment strategy. So I really would like to recommend that you take a look at that webinar we presented last year for those additional details. So this year in 2023, we transitioned from that needs assessment towards recommending action plans in the 3 regions. And this took actually a lot more time than we initially expected. We kind of thought we would magically go from the needs assessment to the action plan. And we had a big challenge ahead of us because in all 3 regions, we were working with multiple counties. And so it wasn't just one body that we were working with, but we had to look across county lines and form partnerships to identify actionable activities, and in a lot of cases, recommendations included changes in public policy and opportunities for advocacy. So these recommendations were informed by the findings from the listening sessions that we presented to the advisory committees. We also looked at sample programs and policies from other communities across the US, and our committee members themselves brought great expertise and had a wealth of ideas to share for potential action items. And these recommendations kind of became split in 2 categories. In one category, they're really actionable. So it might be an event or a program that we recommend be implemented in the region, while others are really advocacy focused, and they might not even be able to be implemented at the county level. It might occur at the state level or even the federal level. But most of the recommendations require collaboration across agencies and sectors. So we took the findings from the needs assessments and the recommendations, and we're creating reports in the 3 regions right now. The Riverside and San Bernardino County and the Shasta, Butte, and Glenn County reports should be ready by the end of December. And the Kings Tulare County report will be ready in the beginning of 2024. And these reports have much more detail than we could ever cover today in the webinar on the findings from the needs assessment and the recommendations. And so we will definitely share them out with the registration list from the webinar today to make sure you can access these and find the additional details that we can't cover today. So while we were drafting these reports, and it was really an iterative process with the advisory committees to make sure that we're capturing their input, we planned local MPA events in the 3 regions. And these occurred in September and October this year. So here on the slide are some photos from the Inland Empire event that was held at the Inland Empire Health Plan. Everyone who attended the event received a printed copy of these recommendations that the advisory committee came up with. There were about 60 recommendations for implementation and advocacy across housing, transportation, healthcare, behavioral health, Alzheimer's, and caregiving. And it was amazing to see on the stage statewide and local leaders voicing their commitment to implementing the recommendations, and to commit to incorporating some of the advocacy recommendations into their own advocacy platforms for the next year. And after the event, the San Bernardino Director of Behavioral Health came up to us and said that they were interested in helping to lead implementation of the behavioral health recommendations and really wanted to get involved in supporting and implementing the local master plan for aging. And that was just one person. There was multiple people that wanted to get involved after the event. We held a similar event in Kings and Tulare County, and there was a standing room only crowd of 300 community members and professionals, and representatives from both the County Board of Supervisors and other community leaders voiced their commitment to the local MPA. And just after that, literally the next day after that, was the event in Shasta, Butte, and Glenn County, and that was held in Red Bluff. And after meeting on Zoom with the advisory committees for months, I don't think we realized how big of a catalyst these in-person events would be for building local support, including engaging key influencers such as elected officials and county leaders that will be invaluable champions as we move forward in each of the 3 regions. If you're interested, all 3 events were video recorded, and we're also working on creating highlight videos for each event. So we hope to share those out with you in the near future. The events also provided the added benefit of sparking media attention. On the left here was a column published in the King's Tulare local news, describing the findings of the needs assessment and recommendations in that region. And on the right are 2 media spots highlighting the Inland Empire Master Plan for Aging, including at the top, the PR Newswire, which reaches a national audience. And at the bottom is a screenshot from a 20-minute radio interview with the local radio station. So now that you have an idea of our scope of project, I'm going to transition our webinar to discussing our needs assessment findings and recommendations. We're going to start hearing from Carolyn Nava, who represents Shasta, Butte, and Glenn counties. And while the local master plan for aging reports will highlight the full findings of the needs assessment and recommendations, as I mentioned, in our webinar today, we asked each region to provide a brief overview of 2 different topics, 2 different domains. So Carolyn's going to focus in on healthcare and housing for her presentation. So I will pass it off to you, Carolyn.
Thank you so much, Pauline. It's important to emphasize that we are just getting started with this entire project. And while we are definitely identifying a lot of similarities between the rural regions, there are also some unique elements that are specific to that area. And that's what I hope to distinguish in this brief moment of time today. So in our northern region, starting out with healthcare, the best way to emphasize what's going on in our region was coming directly from the comments of the individuals that we were blessed with opportunity to interview in our listening sessions. For example, in the questions that were submitted at registration, someone asked, well, how do you manage this from day to day? How is the community managing? And the comment here on the screen about the understanding of elderly persons in the apartments where someone lived, that they always targeted the apartments that had the elderly in it. So they were taking it upon themselves as a neighborhood network to clean their house, wash their dishes, do their laundry, cook meals for them. But you notice that last comment, sometimes it just gets hard. And that energy is what we believe with collaboration can change throughout our region. Our healthcare sessions, they did focus on mostly provider availability, which is dismal in our region, non-emergency medical transport, patient safety and security, including thoughts around racial and gender identity discrimination, and we'll add to that ageism. There's only so much space on these slides. So the gaps in eligibility and services is really a critical element for us to focus on moving forward, along with the discrimination and the demographic changes within the neighborhoods, leading to a lot of cultural differences, especially in the wake of the emergencies that our North State has experienced. Over the last 5 years or so, we have had a major FEMA declared disaster once every quarter. So we have just been inundated with challenges in this region that gravely affect our communities where we have aging or those who are disabled. More than half of our territory is over age 65. Now that happens because mainly a lot of the territories that we have are rural and affordable. So when these areas experience the disasters, it affects healthcare. We saw it post-Paradise Fire. Paradise, California lost the major hospital in that region. That left a lot of elderly individuals who live in those foothills without appropriate medical care or transportation to get to a closer facility. So managing from day to day is not that easy. We also have a lot of that population that not only is experiencing physical disabilities, but vision loss, which is quite natural to aging, actually, for many. but we don't often think of it as a disability per se. It's just the eyes get a little fuzzier, or you don't like to drive at night anymore. But that's a real concern. And many of what we noticed as well is that many of the programs and services that are available, the community at large is not aware of them. So getting the word out in this rural region is a critical, important next step for us, which we'll be talking more about now, next steps in a moment. But if individuals don't know where to go or what resources are available in their community, then we have to look at filling in that gap of having a broad-based, multi-pronged awareness campaign. So that's something that is really in consideration for our region. And as we move into the next slide, we began to see some of the impact of the differences within our immediate region. For example, when we compare this dark green North State area at the top of the state of California to the balance of the state, our far northern region has a much higher premature death rate or overall death rate, as well as higher death rates from things like cancer or unintentional injuries or motor vehicle crashes and suicide or firearm and drug-induced. The list is endless, but those were some key highlights. And another thought that was brought out was the effects on our older rural and indigenous Californians. I noticed that in those questions or comments coming forth. And even though we often think, let's turn towards our indigenous population, our tribal community, Northern California has the largest amount of tribes in the state. So we have a lot of tribal communities, and we work very hard at maintaining those tribal relations. Population-wise, in terms of minorities, our Asian American population, Hmong Mien, comes in third place in terms of population. They're about 5%. First place for minority population is our Latino community, which comprises about 15% of the region. The two smaller ones, in Native American, African American, Native American coming in at about 2%, African American coming in at about 1.7%. So that racial uncertainty definitely exists in this region. Our population is mostly white. And that brings up a lot of cultural uncertainties, misunderstandings that our work through this activity, the master plan for aging, the listening sessions, is bringing to the forefront. And I'll add to that our LGBTQIA plus community as well. Definitely received those comments about racism, about non-inclusion, about insecurity, and not feeling safe in the territory. Now, when you have that, it kind of combines into housing situations. So as we look at that next slide, we see some of those comments that came about housing from the community. These were real comments. We mentioned the Paradise region, and a lot of that affordability was suddenly gone post-fire. People living in what we call the red zone. That is the PG&E territories where power is very unstable. So we have major storms come through. That means you have seniors, you have people with access and functional needs left without power, sometimes days at a time. Last year's winter storms left people living in the snow. Some people were intense in the snow. Some of them elderly, living in houses that are no longer suitable with holes in their floors. We had one elderly person literally living on their porch in snow freezing temperatures because the house was no longer suitable to live in. This is the reality of what we are living with because they're only affordable housing. These disaster-related housing shortages, it's not that we're the only ones with housing shortages, that is statewide. It just seems to have been exacerbated up a notch in this region because it is so rural. And to be honest, contractors have left the North State going down into more populated areas to get work and to stay actively working in some of the other regions, more populated regions that also experienced fires. So we've been kind of last in line. 6 years later, we still have individuals living on trailers on their properties without proper utilities. Some people 5-6 years later, still have not been reimbursed with their insurance companies to get back on their feet. So we are not over with this crisis yet. You know, we have grandparents caring for grandparents. Again, these are all things happening in these larger regions. They just seem exacerbated by the limited resources or the lack of knowledge in some cases about the resources that are available. So we're not done in this region. We're continuing. We're blessed to receive additional funding to continue this work. So we will dive deeper. And as we move into Sharon's comments later in our slide presentation, she'll talk about some of that importance of our area diving deeper and also picking up another county to make a four-square approach in the larger populated counties. So as we move into this next year, we'll be adding Tehama County into this body of work as well, along with Butte, Glen, and Shasta. So as we kind of wrap this up, I hope I'm not going over my time, Pauline. I didn't see my start time, but these early recommendations I've kind of been integrating into my thoughts here. Advocacy, definitely required. Advocacy for affordable housing, identifying, you know, innovative programs like identifying individuals who are overhoused. We've been working with our house sharing agency in our Butte County area and looking at ways to expand their activities, stabilize their activities so that we can find more individuals out there who have house sharing ability. Improving and coordinating communication amongst ourselves as providers. We have tremendous collaboration and networking in this northern rural region. So we're not in any way disheartened by some of these results, which may seem overwhelming and leaning towards the negative. We disagree. They're just eye-opening, and they help us to understand where we require to focus, where we require to target our attention and energy.
Great. Should we transition to the next region, Carolyn? I think you're on mute.
Sorry about that. I was thinking you were transitioning. So yes, I want to make sure that our other regions have plenty of time, and I didn't use that time marker. So my apology on that, Marlene.
Oh, no problem. No, thanks, Carolyn, so much for your comments. I think that really helped to give us an insight into some of the unique needs in your region, particularly related to natural disasters and the ongoing repercussions of that. So next, we're going to transition to the Kings Tulare region, where Helen Miltiades will present on caregiving, unmet needs, and recommendations, and Dana Wild will present on education and awareness.
Well, hello, everyone. In Kings and Tulare County, we first started out really focusing on caregiving, housing insecurity, and nutrition insecurity. And through the process of interviewing, we discovered there were some other sort of unmet needs. And that is when we decided to start asking questions about knowledge gap and focus more on outreach. And also transportation became important as well. So I would just say, if you're going to do this, be flexible with what and be responsive to what your interviewees are telling you as well. Just, you can go to the next slide. I just wanted to briefly go over some highlights that kind of crossed all categories. And I decided to do this because we were looking for sort of needs and looking at challenges, and yet there's so many positive things that everyone is doing in our region and across the other regions as well. And one of the things we were pleasantly surprised about was that people who actually were connected and receiving services, they were mostly satisfied with the services. And they said things such as, we wish we'd known about this sooner. And of the people who were receiving services, their suggestions were more wanting more services and increased services. And many of the expressed unmet needs were actually due to people not being aware of existing services. And perhaps not surprising is that many older adults weren't even identifying as having unmet needs. So it's difficult to discuss your needs if you don't even recognize that you have them. And the example I always like to give is the one person we interviewed who was providing care for her husband and was also taking care of her sister. And yet she herself couldn't take a shower or in her own house because she couldn't lift her leg over the bathtub. Next slide. So I'm really supposed to be talking about caregiving. And in the way we did our survey, caregiving included receiving help from family and friends, as well as receiving help from paid caregivers and or in-home supportive services. Both caregivers and persons who were receiving care discussed their unmet needs and their challenges. Some of the caregivers were caring for younger family members who were living with disabilities. Other interviewees may not have been providing care, but they had friends or family who were receiving care, and they also participated in answering questions about caregiving. Surprisingly, we had 33% of our interviewees were either current or past caregivers, and 25% were receiving help from caregivers. And we didn't necessarily target caregiving or people who were receiving care. This was just how the survey fell out. So I think it goes to highlight the unmet needs in these rural, at least in these two counties, rural population. So key findings included the need for caregiver support in 3 areas: training and navigating the social service and healthcare system, which I'm calling mentoring and support, and respite. First of all, caregivers wanted training on caregiving in general. So they expressed the need for continued training as the care recipients' health needs evolved, for behavioral issues related to cognitive decline, managing finances, and understanding changes specific to health conditions, especially as health conditions worsened. One example was they wanted understand better how to manage diabetes. Additionally, they lack knowledge about existing programs and services. So many of them in our particular area didn't really know about the Alzheimer's Association programs, or they didn't know about the Central Valley Caregiver Resource Center and the adult day programs. Second, they experienced challenges navigating the social and medical system, and they lacked access to services in rural areas. They wanted better connections with service providers, and they wanted better guidance as they navigated the social and healthcare system. So they were looking for not just assistance in entering the system, but they also wanted better connections throughout their journey with social and human service providers. Another thing that they identified was the need for respite. Many of these families did not qualify for in-home supportive services support. They weren't able to afford formal caregivers. And in general, there's just a shortage of non-family caregivers who could help even within the in-home supportive services system. So some of our recommendations were, I guess our first strategic priority would be building formal and informal caregiver capacity through training and access to resources. And that would be more support groups, more respite services, caregiver training, looking to raise awareness of adult daycare providers and their sliding fee scale, increase awareness of existing services through social media, connecting with non-traditional providers, holding resource fairs. One of the things we discovered is churches are a great way to get information out. Many people relied on them. And just advocating for coordination of care and streamlined communication between organizations and other agencies in the health and human service fields. I think I've gone over my time, Pauline.
That's all right. Helen, are we transitioning to the next?
Yeah, I want to make sure that Dana gets her time in, so.
Okay, sounds good. There's so much to cover today. I know we're going through a lot really fast. Go ahead, Dana.
All right. Good
She's
morning,
on
everyone.
outreach.
Yes. Good morning, everyone. I'll be covering our outreach category. And again, as Helen said, this was not a category that we started with. It was, but because so many people had stated that they did not know about our services, we made this one of our categories, one of our priorities. So again, similar to transportation, outreach was not a specific category, but that came up as a barrier many times. You can go to the next slide. So one of the things that we're trying to do is to increase awareness. And we need to, one of the things that we've found is that we always want to go with the same providers. We always want to have the same people at the meetings. So we need to think outside of that box and bring in more non-traditional providers such as public servants, the officers, those in emergency services, and really increase opportunities to provide information at healthcare, health and resource fairs, and non-traditional venues such as farmers markets. So again, just increasing awareness anywhere we can, and not just going to the same places, but really thinking outside of the box and making sure that we're meeting seniors where they are. And you can go to, so the next, and then access. Another thing that we discovered was that a lot of our material was in English, and we do have a lot in Spanish, but there's also a lot of other languages that we need to think about. So we need to make sure that we're providing materials in every type of language that we can think of that provides access and awareness to our seniors and those with disabilities. And also providing those materials to all of our providers, again, thinking outside of the box, doctors' offices, again, emergency services, anybody that we can think of that may be touching seniors and those with disabilities. So some of our action items, one of the things that we did first is we created what's called a roundtable, and we started monthly meetings. And one of the things that we did at our master plan for aging event is we created a table where we had people go over and provide suggestions and input, and if they wanted to be part of the roundtable, to give us their name and number. And we got probably about 40 to 50 people that said that they wanted to be part of our roundtable from various different organizations. Again, organizations that we just don't normally even think of. And this is, it's working towards a coordinated care. We were very lucky that one of the people that were on our advisory committee was also, he's our director for the 211 Center. And he said, hey, I would be more than happy to offer 211 as that single number. So one of our first action items in this roundtable is coming up with just a simple pamphlet to give to the seniors, not one that has 50 different numbers on it, 50 different organizations, but a simple pamphlet that says, here are all the different services that we can provide to seniors and those with disabilities. And if you need those services, call 211. And then on the back end, we're creating this complete mapping process that 211 is going to have, that they will know about every service. They'll know who to call. They'll have keywords. So if somebody says, I need food on the weekends, they can put in food on the weekends, and it will bring up providers that provide food on the weekends. The other things we're going to be doing, of course, is a lot more health fairs and outreach. And the goal is that the more we come together as a community and we each know what other, what we're doing, so that we're all together, we're all taking this one pamphlet that has all the services on it with that 211, and we all know what each other's doing so that the seniors are not getting lost. That's what we found most, is that the seniors, even if they maybe know about our services, they don't know which door to go into. So we're trying to keep that, to create that one door policy. And again, like I had stated, that we had asked for suggestions. We received a lot of suggestions and feedback, things that we didn't even think about. And at this roundtable, once we get that pamphlet and we really feel like we have a good coordinated care one door policy, then we will start working on other things that came from our from the master plan from aging, some of the suggestions, and also working on towards some of our priorities. Again, they had a lot of great suggestions for us.
Thanks so much, Dana and Helen. That's exciting to hear that you got so many people signing up for your roundtable at the Master Plan for Aging event. And I have to say, as a participant at the advisory committee meetings in the Kings Tulare region, it was really apparent how much collaboration there was in that region. Sometimes our advisory committee meetings almost turned into a multidisciplinary care team with a particular complicated case being discussed and people offering up services and saying, hey, don't you offer this? And I really appreciated that, witnessing that in your region. And I'm excited to hear about these next steps.
Thank you, Pauline.
So now we'll transition to the Inland Empire. We'll have Elizabeth Bogomil present on transportation and Carmen Estrada presenting on education and awareness.
Hello, everybody. It's wonderful to be able to talk to you a little about our findings from the focus groups that we held, particularly with concerns to transportation. I'm going to start by talking about two of the experiences from our focus group participants. First of all, a rural individual says, I don't drive no more. I have the bus passes, but can only ride the bus to the store one day, or I can come here to the senior center 2 days. Shopping is hard because you can only take so many bags, and I can't carry that much because I have to use my walker. And this was an individual living in a rural community, and they were talking about their experience with the bus. It's not that they can't take the bus more frequently. It's simply that the bus route that goes by their house to a more populous area only comes by 2 days a week. So they have to make a choice of where they want to go, whether they want to access social interaction, medical facilities, or food. And so they have to make those choices and strategize. And we also have an LGBTQIA individual speaking about their experiences with driving. It's scary not being able to drive, or the idea of not being able to leave the house freely. And so this is discussing the potential of losing one's license due to vision or other health or physical abilities. And that fear behind it, and how that fear permeates their ability to access caregiving, potentially healthcare, or behavioral health and social support networks. And so through these focus groups and listening sessions, we found out that transportation was really the uniting factor with all of the subjects that we discussed. Essentially, all roads lead to transportation. Our topics of housing and healthcare, behavioral health, Alzheimer's, caregiving, all of those and access to those were dependent on whether an individual had reliable access to transportation, and not just reliable access, but also where their location was and whether they were considering staying in that location, or whether they actually had to move out of the county or out of the region or the location that they were in to access services more reliably with transportation. And so our next slide discusses some of our transportation findings. We divided our findings into two sections: public transit and driving. Public transit includes buses, Uber, Lyft, trains, that sort. And driving was just the ability to drive and access what was needed individually. Everybody who spoke about public transportation and using it gave great accolades to the kindness of the drivers. So people who were driving the buses or the access vans were saying that the drivers were very, very helpful, very supportive, actually were able to kind of direct them towards resources, help them bring the bags that they needed onto the bus from grocery shopping, help them unload. So they were very appreciative of the kindness of drivers. However, public transit needed to go where people wanted to go and needed to go. So it needed to go to healthcare facilities, not just go there, but it needed to drop off out front of them rather than trying to figure out, leave it on the individual trying to figure out how to cover the last mile or last bit of distance to get to where they needed to go. It needed to drop off at senior centers, at social activities, at grocery stores and pharmacies. And then also, really importantly, which is oftentimes forgotten, locations of low-income food distribution centers. And this is particularly the case out in more rural areas of the county. So Riverside and San Bernardino are very large counties, and there's certain areas that are more populous and have more networked public transit. And there's other areas that have limited or no public transit, or they're just implementing like a bus service to be able to connect people once a week to resources that are needed in larger areas, populous areas. So that's important to consider when thinking about people discussing transit in these focus groups. And then there was also discussion of carrying things on and off the transit. While drivers were kind, there also was rules in terms of what could be brought on the public transit and the amount of things that could actually be carried and navigated. There needed to be a link with care and housing. So transit was used to access direct people from their housing to be able to access resources, and then also care as in caregiving, but care also as in healthcare and behavioral healthcare. So individuals who were using public transit really needed to be able to access healthcare facilities and not have to worry about that last mile or that gap in space, which in some cases maybe could be connected by a bike. But if you don't feel sure riding a bike, or if that's not the direction that you want to go in, you want to be able to get directly to the healthcare facility from your home. And then also with public transit, there were issues surrounding occupational health, access, and dial-a-ride. Particularly those challenges were with concerns to timing, the frequency or the time of day in which they could do pickups and drop-offs. There were issues surrounding no-shows or late pickups. And when that happens, it could sometimes take months for somebody to schedule an appointment with a specialist and to be able to get time with them. And if a no-show or a late show happens, they're late to their appointment, and oftentimes that appointment is canceled entirely. So that permeates their need to access like reliable healthcare. If they don't have reliable transportation, their healthcare also dwindles. And there were also issues with restricted and limited times and places for which somebody could use the transit. So for example, with certain types of occupational health or access transit, if an individual needed to pick up a prescription, they were able to do that on the same day consecutively, like in line with their doctor's appointment. But if their prescription wasn't available, for example, till the next day, they maybe couldn't use the healthcare transit that they were hoping to use to pick up their prescription. And now they have to figure out how to navigate picking up their prescription. And so that was an issue that could be looked at further and examined. Additionally, with driving, we found that caregivers or individuals who were receiving caregiving got a lot of support through that. So either caregivers were driving individuals who were receiving caregiving to their appointments to be able to access groceries, or people who were providing caregiving were doing the driving to those who needed it. But those who were driving, whether they were caregivers or individuals who were aging or disabled, had a huge problem with dirt roads. So there's certain areas of Riverside and San Bernardino County that just have dirt roads. And when it rains or when the snows melt, there's ruts in the dirt. And there's a particular story that stood out to me where an individual tiny lady was talking about lashing a large mattress to the back of her car so that she could then drive with the mattress behind her to smooth out the ruts for her neighbors. So that was just incredible that that was something that she needed to think about doing. There were also long distances to get to necessary resources. And that could be, for example, to get to even public transportation. If an individual was on a dirt road, public transit doesn't come up a dirt road. So they needed to then go down the dirt road, figure out how to pick up the bus, and then get to where they needed to go. Or just being able to access behavioral health care or regular health care or groceries. In some people's cases, the distance to get to the location that they needed to get to was so long. And in some cases, individuals feared having to drive at night because of vision impairment. And they didn't want to be stuck at a place that was a far distance away, having to drive at night on the way back. And there was a strong feeling of losing their vision and the fear around that. And so when we think about recommendations and some of the recommendations that were discussed within our advisory board, they fell into two general categories: implementation and advocacy for public transit. Implementation, we focused on collaboration. So collaboration with Public and Specialized Transport Advisory Coordinating Council, which we just presented on in the last month, and got some really good discussion going there and collaboration happening. We also discussed holding summit meetings on transit. Since we've discussed this, we've met with Riverside and San Bernardino counties and their transit groups to discuss some of the challenges people have been experiencing. Also collaborating with agencies that engage in volunteer drivers, which we were able to connect with through PASTAC, and pair senior centers needing buses with unused shuttles, or in fact, in some cases, with large grants that were available, but just weren't being taken advantage of through transportation agencies to provide these shuttles. Additionally, figuring out how to address paratransit needs among the disability community in Victorville and in other rural communities. And then with implementation, we also focused on training. Training healthcare providers and providing resources to drivers when their licenses are revoked, how to discuss that, and providing that before people became worried about the scenario. And then also launching Peer Navigators program for transit, which we found out through PASTAC does exist in certain regions, but it's could be expanded further. And then also advocating for public transit, improving regulatory and quality of public transit, also looking into free and subsidized rides for older adults, and then transit to connect older adults to relevant locations that they needed to go. And so these were some of our recommendations. And I am going to pass it off to Carmen now, who's going to talk a little bit about education and awareness.
Thanks, Elizabeth. So as mentioned, the Inland Empire MPA Advisory Committee, we initially selected 6 domains to focus on through discussion of the findings from the focus groups. And as we listed the recommendations for each domain, a 7th emerged as greatly significant. Community education and awareness is really at the center of how we can tackle some of the challenges voiced throughout our focus groups. As we conducted the focus groups, we listened, we learned, and we adapted. There were times we had to reframe the way in which we approached each topic, depending on the understanding of participants, and also depending on how they viewed themselves. For example, when we discussed caregiving, some participants did not see themselves as caregivers, although they were providing care. We had to clarify if we were speaking about home health providers or family friend caregivers. When speaking about behavioral health, terms like psychologist or depression were not well received. To begin these conversations, we needed to ask questions like, what do you do when you feel sad? Or who do you go to when you're not feeling up for anything? Gradually, the terms were included in the discussion again, and participants were very honest about how they felt about these terms. One participant from our Spanish-speaking caregiver focus group stated, en nuestra cultura es difícil aceptar la necesidad de un psicólogo, meaning in our culture, it is difficult to accept the need of a psychologist. When speaking about Alzheimer's and other dementia, some participants viewed memory loss as part of the normal aging process. In one of our Spanish-speaking groups, the term lagunas was used by one of our participants who said, oh, sí, ya estoy padeciendo de esas mentadas lagunas. One meaning for lagunas is lagoon, or narrow body of water. But she was using the term to refer to memory gaps. So really what she was saying is, oh yes, I am now experiencing the so-called memory gaps. The terms being used and the knowledge of the audience are important to note because any disconnect can affect access to services. So these examples caused us to reflect on whether or not services are being promoted appropriately, and are we as service providers using the right language to reach target populations? The answer in this area is that obviously it's something that can be improved upon. In general, we found that focus group participants had very limited knowledge about the array of resources available and how to access them. For example, with transportation, there are programs that offer travel reimbursements, dial-a-ride, or even there's transportation funds available to nonprofits that nonprofits could apply for. Housing, there are agencies that provide minor home repairs. There's information and workshops on financial planning and reverse mortgages. So these are just examples of some of the resources that our participants were not familiar with. Additionally, we found that agencies and service providers are sometimes siloed, and there is a need to continue to encourage consistent collaboration, not only with regards to the services being provided, but also with the goal of offering age and disability-friendly access. Lastly, the focus groups highlighted the need for aligning services and supports with cultural needs and values. For example, how we speak about aging, how we speak about behavioral health and social supports, about caregiving, about Alzheimer's and other dementias. This means not only obtaining DEI training, which I know a lot of us have been participating in these past couple of years, but also implementing what we learned to help adapt the way that we provide services to diverse groups. Go on to the next slide, please. So based on the fact that community education and awareness can help address challenges and gaps in services across the 6 domains important to the Inland Empire, the advisory committee came up with 2 overarching recommendations. The first is reframing how services are being promoted in the community. And the second is launching education campaigns to enhance knowledge of resources and aging-related topics. Specific campaigns the group would like to focus on are existing resources for older adults, people with disabilities, and caregivers. Also, awareness about aging. What does aging mean? Really, we are all aging, right? Campaigns about resources and supports to family and family friend caregivers, specifically how to hire caregivers. And then finally, breaking the stigma of behavioral health issues in older generations. And so before we are really able to tackle and work on these recommendations, there is still a lot of work to be done. And that will be discussed in the section about next steps. Thank you.
Thanks so much, Carmen and Elizabeth. So now we've heard from 3 of the regions, and really, again, this was just a very small snapshot of a lot of information. We heard some common themes across the regions and also some differences. So for example, one common theme across all the regions was the need to increase awareness of existing services. And we know there are efforts to coordinate an Aging and Disability Resource Center, or ADRC, underway in the North State region and in Riverside and San Bernardino counties. However, in Kings Tulare, there were some regulatory barriers to forming an ADRC. Another common theme across regions was challenges related to housing, whether it be affordability or challenges maintaining one's home. And in the North State, as we heard from Carolyn, and also in the Inland Empire, we learned that some older adults are living in really unsafe housing conditions with unstable access to electricity, running water, air conditioning, or heating. And some participants voiced a desire to move closer to services, but there were so many barriers to that. And in the North State region, we learned about how the housing challenges were really exacerbated by the massive and multiple fires in the region that increased housing costs and also made it harder to secure contractors, maintain existing housing, and insurance. And in the North State region, the fires also exacerbated the healthcare shortage. And the advisory committee in that region really felt like healthcare was the number one issue that needs to be tackled in the region, affecting all other topics. So overall, we gathered so much data in the regions, and we hope to continue to analyze the data to further identify similarities and differences across the regions. And also recently, the California Department of Aging funded additional rural regions to work on developing local master plans for aging. So I think there's a great opportunity to look at their needs assessment findings and their recommendations, and really look more broadly at the entire state of California at how we can better support older adults, adults with disabilities, and caregivers in rural regions, which is a significant part of the population that has often been overlooked. So now we want to transition to talking about reflections overall and next steps. When we created our initial scope of project, we were really ambitious with our timeline. As I mentioned, we thought we would magically go from needs assessment findings to our action plan. And yet there was a process of about 6 months of trying to figure out how do we address these huge needs and what are the overarching recommendations. In the Kings and Tulare counties, they plan to transition directly to implementation in this next phase. The Shasta, Butte, Glen, and Inland Empire regions received new funding from the Department of Aging to continue to build out their action plans through March of 2025. And the plans developed through the SCAN funded phase will provide a roadmap for the regions. And now this additional support from the Department of Aging will help to build out the how. In the Inland Empire, work groups are being formed to identify timelines, specific activities, and lead agencies that will guide implementation over the next few years. So now I'm going to pass it off to Sharon Brizolara, who has been consulting with the Shasta, Butte, and Glen region throughout this project to share some of her reflections about lessons learned and next steps in her region.
Hello, thank you, Pauline. And so I wanted to share with you a little bit about what is shaping our next steps. And it has occurred to us through this time when we think about barriers and facilitating factors, that there are really two sides to a coin. So like many of the regions you've heard from, one of the challenges of working in rural areas is that many people have multiple roles and responsibilities. So that can both be a challenge in terms of role strain and then number of different initiatives and projects that one has to consider when making asks or when planning. But it also, from a facilitating side, leads to deep relationships and strong networks and the kind of cultural knowledge that Carmen was speaking about present within the group. We also had experience with a lot of turnover in our group because of many of those responsibilities and people changing positions. And we've chosen to really look at that both in terms of part of our efforts to disseminate what we're doing, to have more advocates or constituents in a way out there for us, and to really reflect on what are our roles and responsibilities, how do we engage people, and what are we going to ask of them. We have looked at securing representation by all counties, at least the first, at the beginning, the 3 that were involved. That has been challenging because of some of these other factors, including some political dynamics in one county that can lead to lack of clarity about the best way to move forward. And so while that's a challenge, we also see an opportunity because everyone needs to submit a plan to address this work. And through collaboration, the collaboration is important, not only because of that shared value of a no wrong door policy, but the opportunity to really operationalize that. And we know that we share people across our county lines, as well as many of the challenges. So there is strength in numbers, and many of our groups like Disability Action Center, our United Way, our areas of aging encapsulate, embrace multiple counties. So we see that also as an opportunity. The LADAP that Pauline mentioned, that support as SCAN Foundation has been tremendous support and facilitating factor moving forward. And even when it comes to some of the political challenges faced on some of our county levels, we see this focus and the awareness and care for older adults, how much of our population is there currently or will be in those with the similar needs. We see that as a resource going forward. So part of what we plan to do is to really distribute and engage in participatory conversations around the beautiful report that we'll be receiving, clarifying roles and responsibilities for the advisory committee, for members, looking at ways of engaging people through working groups, and we're revising what those might be, how we support those groups. And also, as we become clear about our choices, really having a clear logic model that will map out what we're doing, the short, medium, and long-term outcomes that we are hoping to support. And for the next slide, Pauline, if you could. I was thinking to myself. I'll just say briefly in terms of our other takeaways that one of the things we really learned was about the importance of clarifying those roles and responsibilities on a continual basis, and that repetition is important given turnover or given people's multiple experiences. We learned to make specific requests when we have a need in our meetings, and also a recognition that our listening sessions often take more time. People want to share more than the time allotted. They take more time to really create, given the relationship dynamic of that, than we initially anticipated, and that we are became increasingly more ready with resources right at the end. So that's what I have to share. Thank you so much.
Thank you so much, Sharon. Now I want to transition over to Dana for some reflections and next steps in the Kings Tulare County region.
Really, I think it's what I had already discussed, and that's that round table is really making sure that we have the right people at the table. We have probably been about 40 to 50 people that have said that they're interested. I saw one comment about the RICV there on there. We have the Center for the Blind, the Deaf and Hard of Hearing. So just really making sure that we have the right people at the table so that we can make decisions together. And then again, I think a lot of advocacy, and also getting out there into the offices of people that we need to get into, the cities, you know, when we're talking about zoning and things like that, they need to hear some of the issues that's going on. And so it's really going to be getting out into the community, really reaching the people that we need to be reaching, and then making sure that we have all of the right people at the table so that we can move together. It's just, it's impossible for 1 or 2 or even 10 people to do this. We need the entire community to come together if we're going to make our, the lives better for our seniors and persons with disabilities.
Thank you, Dana. And now can I pass it off to Carmen for the Inland Empire perspective?
I'm sure. So some of our next steps include, of course, getting our final report approved and start sharing that report so that we can obtain additional feedback. We also want to utilize the report to drive the work groups that we are going to be establishing. We're going to be establishing 3 to start off with, which focus on transportation, housing, behavioral health. Right now, we're identifying champions in the community to lead these groups. We will also be having these groups help us facilitate additional town halls in collaboration with the Inland Coalition on Aging to obtain additional feedback. So there's still a lot of work to be done. The document is more of a starting document that we're going to adapt and change, just like we adapted and changed the recommendations when we shared them at our launch event. Also, we will be applying to become an age-friendly community through AARP, which will help facilitate obtaining additional data through livability surveys. And, our end goal is creating a final Inland Empire Master Plan for Aging, which will be our roadmap for aging well in our community. And in addition to that, we are also focusing some time on sustainability. So finding and locating additional funds to fund some of these recommendations, identifying organizations that could lead those efforts. So definitely still a lot of work to be done, but the energy that we were able to get through our launch event has been great. And so we're excited to move on to the next steps.
Thanks, Carmen. And Elizabeth, did you have something to add?
Yeah, so we were thinking about pathways and kind of barriers to the process. Some of the pathways were being able to secure the laid out funding, and we're going to continue looking for additional funding to allow the project to perpetuate. And then also some pathways to encouraging participation. We're engaging community stakeholders, various agencies. We've started engaging with the transit agencies like I had shared with, and we'll probably start branching out and presenting information to the various work groups that we have that will be made up of community stakeholders and agencies. One barrier that we encountered that I think is just relevant to note is making sure that when presenting information to agencies, coming in with the idea of like, we want to hear what you already have going on. And we're not here to criticize or tell you that what you're doing is not right. We're here to collaborate and figure out how to make this better and beneficial for the whole community. And so making sure that we're framing any kind of presentations or engagement in that way was definitely important to make sure that the work can continue.
A good reminder. So now I know we've covered a lot, and we really wanted to be mindful to leave some time for questions and answers for the audience. We have an amazing group of expertise from around the state here on the webinar today, and welcome your questions in the chat, or you can raise your hand. And I am going to ask Maria, I've seen that the chat has been really busy and I haven't been able to keep up on it. So were there any questions that you might want to elevate at this time to our panel?
So much, Pauline. Yeah, that definitely lots of commentary in the chat and great conversations. I think there was some commentary from Richard that would really love to address as part of this conversation. Richard elevated a number of challenges in accessing care through the IHSS system, particularly for individuals who are receiving support from non-family members within the program. And I really think Richard's comments highlight a broader challenge with California's direct care workforce. Often women, people of color, and immigrants working for little pay, limited or no benefits. These are really demanding and tough jobs, and paid caregivers are largely undervalued. I think the bottom line here is that we can't really meet the demand, the growing need for care without providers. They're a pivotal piece of the puzzle. And so really there's sort of two questions that are circulating. I think that, Richard, feel free to jump in, but come to mind for me. One being, were there any findings or recommendations related to California's caregiving workforce through this process, including IHSS? And then the second question would be, sort of recognizing that access to care is not age specific, but really based on an individual's functional needs. So to what extent were disability groups and individuals with disabilities engaged in this process?
That's a double-barreled question. Lots to cover here. Do we have any volunteers? Carolyn.
I'm going to emphasize that double-barreled question. This is a really challenging topic. It's also a highly political and controversial topic in our region. So if it seems like I'm stepping lightly, it's because I am. One of the things that we found in our region, especially with the increase in wages, is that we suddenly had this barrage of disability action center clients calling in. My role as part of our systems change team, I receive some of these phone calls regularly, but there was grave concern that increases in the wages would make it to where individuals receiving the care could no longer get adequate hours for care. So, you know, that double-barreled situation requires continued screening, a very close magnifying lens to look at the flexibilities in applying this. There's no doubt that wages are not enough. One of the things we emphasized at our launch in October of our master plan for aging advisory committee was the reality that the average 2-bedroom apartment rental in the state of California requires an individual to be making at least $39 an hour. That's for a 2-bedroom apartment. Now, I will emphasize that in our rural region, rentals are about the same as what you see in Southern California. So it's important to understand that in our more populated rural areas, it's not inexpensive. Butte County lines up in costs month per month, pretty darn close to what you're going to see in LA. So what we earn matters, that's no doubt. How we earn it matters, that's no doubt. It's just important as we strike a pin at a legislative level that we break down the parameters to understand what flexibilities do regions have to apply this, to implement it, to work it in that fits their region, as opposed to a blanket legislation statewide. We definitely require flexibilities on these types of decisions. Richard, I hope that helps. There's no easy answers here. It's a continued discussion.
Thanks, Carolyn. I see Elizabeth has her hand raised as well.
I don't have any policy discussion or anything for this, but I can tell you that we interviewed unhoused community members who are aging. And those unhoused community members, many of them, their previous career or their previous many of them didn't have current careers because they were retired. Their previous calling was caregiving. And they didn't make enough with their job with caregiving to be able to sustain a household environment, or they encountered situations where they had been caregiving for someone, that person had passed away, and their housing was taken away because they weren't able to inherit it. And so because of that, it was a surprising number of individuals. They had ended up unhoused because of that. So something to consider when considering how much caregivers are paid.
Sharon.
Yeah, and I agree with everything that Carolyn is saying, and that's something that certainly has come up, you know, for us. And we also had a recommendation to advocate within the where we could for higher wages. We had some similar recommendations about recruiting related to recruitment and retention of providers more specifically. So to both end.
Mm-hmm. Mm-hmm. Yeah, I see a comment in the Q&A that many of these issues being identified are urgent, while the time frame for collaborative planning is more gradual. So how do we advance urgent concerns such as provider rates to decision makers in a focused way while continuing the general work? Carolyn.
That's really an excellent question, and it's something that we are giving active consideration at many conversation tables in our region. And what we're realizing is, yes, as Sharon just mentioned, that advocacy, that delicate piece of screaming being what I call the loudest dog barking in the yard, so that we get attention brought into our region. There are many, many, many sources of funding. It does not always have to come from those traditional areas. And so in our region, we are looking at even those private level funders who have a passion for this type of work and getting grants from external state, external federal sources to help in this way. That's something that I know our center, the Disability Action Center, is a center for independent living. We get, limited funding from state or federal. So we're actively looking at what can we do to bring in additional funding that will go directly out to our community. We're working with our local hospital networks. We're working with managed care plans. All of this to find pockets of money targeting the challenges that we're seeing right now. And maybe we can't make a difference on the wage side, but we can make a difference in other ways that can take the pressure off, especially for family members that are caring for one or multiple individuals. That's a really tough situation. What we're doing is looking at alternative ways, thinking outside the box. Money can help in many ways. It doesn't have to go directly to the wage. If we can help lower costs for someone or help augment assistance in another way in that home for that individual, that's going to help. So time will tell, but we're just actively pursuing sources of revenue outside of state and federal to help stabilize our community.
Mhm. Yeah, and I'm just thinking out, there's a few of us on the screen here, but we're representing our advisory committees in the region. And on each of the advisory committees, each individual is really passionately also working on all these issues. And in the past, everyone's kind of worked in their own silo, and we all had our own strategic plans and our own deliverables for the year. But this master plan for aging brings regions together and says, like, how can we better work together to move that needle a little bit faster? Sharon, I see your hands raised.
Yeah, I would just add, Richard, I think it's something we all struggle with, but one of the things that became clear to us that others have articulated is that there were a lot of resources and connections people were not aware of. And so where could we make sure that we are supporting and resourcing each other, that we make sure that community members know about things that emerged as wishes, those kind of needs that we can take care of, and other ways that we can be more efficient in terms of supporting groups who are doing something that's really needed, and other groups perhaps turning their attention to referral and addressing other needs.
Thank you, Sharon. And I feel like our conversation could continue for another hour probably. And even just in the registration, so many of you listed really great questions that I think warrant further discussion. Unfortunately, we're getting close to the end of our time for the webinar. So I am going to transition it over to Maria. But before I do, I just really want to thank all my colleagues for their work day in and day out, and for all the information shared on today's webinar. And Maria, I know that we are recording the webinar, and that we also do plan to share the slides from today, as well as to follow up with links to the local master plan for aging reports that are being created in the regions.
Yeah, absolutely. I just want to thank everybody for their time today. This has been a really riveting conversation, and I'm so inspired by all of your hard work on the ground to build age and disability friendly communities that work well for everybody. It's really a tremendous lift and a lot of work, and we should recognize that it's no easy task, but the passion that you've put into this is really fantastic. And absolutely, for everybody joining us today, the session is recorded, as Pauline mentioned, and we'll be sending that out to you next week. If for some reason it ends up in junk, or you miss it, or you can't find it, you've got my email. Please feel free to reach out at any time. And really looking forward to this continued partnership as you all advance the local MPA plans, as other regions start to engage in this process and move along their own age and disability friendly plans. and as advocates at the state, continue to push the momentum of the master plan for aging forward. So thank you so much. I hope you enjoy the rest of it's Wednesday, I think, Wednesday. And we'll be in touch soon. Thanks, everybody.
Thank you
Bye-bye.
so much, everyone.